Hello everyone. My name is Jen Nolan and I'm the Policy and Programs Manager at Musculoskeletal Australia, and I'd like to warmly welcome you to our webinar on the topic of gout this evening. In line with Musculoskeletal Australia's focus on empowering consumers through education and support services, we are again offering a series of webinars for a consumer audience during 2020. As you can see from the list of webinars on your screen now, they cover a range of topics. If you wish to register for other webinars in the series and you haven't already done so, please go to our website at www.msk.org.au. Whether registering for the webinars or not, can I urge you to have a thorough look through our website where you'll find an extensive range of information, films and videos, apart from our other initiatives and services such as our peer support groups, our MSK Kids program, our MSK Helpline, our Active Neighbourhoods for Older Australians project, among many other things. Our presenter for this evening is Dr Tina Racunica. Tina is a consultant rheumatologist and the Director of Southern Rheumatology, her private rooms. She treats adult rheumatological conditions, including the inflammatory arthritis, other connective tissue diseases, musculoskeletal complaints and osteoporosis. She's also qualified in musculoskeletal ultrasound and incorporates this in her practice to assist her in her rheumatology practice. Her main focus is in clinical practice. Tina trained in rheumatology and completed her physician training, gaining her RACP fellowship in Melbourne at the Alfred Hospital and Monash Medical Centre after completing her medical degree at Sydney University in 1999. Prior to this, she was a pharmacist in the RAAF and also worked in several hospital and retail pharmacies. Without further ado, I'll hand proceedings over to Tina. Thanks very much, Tina.
Thank you, Jen. Thank you. Hello, everyone. Good evening. Welcome to talk on diagnosis and management of gout. Thank you to Musculoskeletal Australia for inviting me to give this talk, and I'm hoping that you'll get something out of it tonight. These are my disclosures. And these are the key messages that I would hope to get across to you tonight. Gout is treatable and preventable. Sometimes it's tricky to diagnose and treat effectively though. So there are a few rules that we want to go through to help you understand why we do the things that we do as doctors. Once we diagnose gout, then we aim for a serum urate, which is a specific blood test, to be less than 0.36. If people have tophi, which are lumps of gout crystals, then we want it even lower at 0.3. So this is a special blood test that is monitored by your doctor. So first of all, just a little bit about what is gout. Gout is what we call a crystal arthritis. It means that the joint becomes inflamed due to crystals being there in or near the joint. In some people, crystals of uric acid or urate deposit in the joints and around the joints and the tendons, and it can be anywhere in the body. When we get lumps of the crystals forming, we call them tophi, or as a single, a tophus. Crystals can destroy the joints as well, so I'll show you some pictures later, but it can take like bite-like lumps out of the bone and destroy the bone. Urate builds up in the body over time unless changes are made to the diet or the medications, and that can lead to then having gout. We call that hyperuricemia, when the body has too much urate in it, in the blood. Now urate, oops, sorry, go back a slide. So urate comes from the breakdown of cells mostly. The more cells that are turning over, for instance, if someone has a very rampant psoriasis, it's a high turnover of skin cells, then they can get gout, or a cancer that's turning over fast can sometimes give on gout, but they're just some rare causes. But if cells are turning over a lot, then then you can get more breakdown of cells that leads you to getting urate. Some foods are also high in substances we call purines, that when that's broken down, that increases the gout as well. Now, urate is removed by the kidneys. So when the kidneys are not working very well, then the urate builds up. And I'll show you a diagram of this in a moment. We also know that some medications can reduce the urate being weed out by the kidneys as well. Gout can also be associated with metabolic syndrome, and that is when you are overweight, have high blood pressure, have high blood sugars, and high lipids or high cholesterol. So this is the diagram I was getting at. Dietary intake of foods high in purine, for instance, will increase the amount of urate, which is in an orange sink here, representing like water. There's also some production through the liver as well. And then to come out of the body, the kidneys have got to get rid of it. But if the kidneys aren't working, then this gets blocked and this builds up and there's more urate then in the body. And eventually that deposits out into the joints and the tendons. So what I'd like to do now is illustrate how we diagnose and manage gout through a case. And this case is Mr. AB. He's 49 and he's had 2 days of having an extremely painful swollen left ankle. He's otherwise well, not taking any regular medications. He drinks 2 to 3 beers a day and 12 on weekends. He'd had a similar episode, but it affected his big toe, and you can see a picture of this on the screen. This occurred 6 months ago. At the time he took ibuprofen, or Nurofen, you might know it as, and it settled down after a few days. And this time when he tried that for his ankle, it didn't work. He'd had no other signs of infection, he'd had no fevers or sweats, and he was well otherwise. Now he has a picture like this, a hot, red, swollen left ankle. It's exquisitely tender, and it's limiting his movement of his foot. And just as an aside on the examination, he was also overweight, but the rest of the examination really didn't show very much at all. So some investigations were done. And the first investigation was joint fluid. So we take fluid out of the ankle and we send it off to be looked at under a microscope. And we do that for a few reasons, if we can. So we exclude infection. We try to prove gout by looking at urate crystals, and I'll show you a picture of this a little bit later. So if we can, the best thing before the diagnosis of gout is made is to try and get some fluid to prove the diagnosis. He also had some blood tests which showed high levels of inflammation in his blood, which is fairly typical of gout. He also had normal kidney function. His serum urate was 0.39. He had normal lipids or cholesterol, and he had normal glucose as well. Now the reason why I've put those in is because we also like to look at risk factors for gout, and we wanted to make sure that he didn't have metabolic syndrome as well that would need to be treated to help with the gout. His serum urate of 0.39 is in the normal range, but when someone has gout, quite often the urate level will drop, and it goes up again after the gout attack has resolved. So it's not always very accurate at the time of a gout attack, and we usually like to test it again when the person hasn't got the swollen joint. Now these are the pictures I mentioned about the urate crystals. What you'll see is this picture of the toe that's all inflamed and red looking, and there's this white patch here which is a tophus. The gout crystals look like almost toothpaste when they're hot, and otherwise like a hard white rock. And that's the urate crystal tophus. When you take a sample of that and look under the microscope, it looks like needles. That's what the crystals look like. And then we use a special polarizing microscope that then confirms whether it's urate crystals, because they look green in one plane and red in another. So that's very typical of gout crystals. You see lots of them, so it's fairly easy to get the diagnosis. We can't always take fluid out of a joint this big. Often we need bigger joints like the knee or the ankle joint, so it's not always easy to get the joint fluid. Sometimes gout can mimic other arthritises as well, so it's not always easy to just say, oh, this is gout. A big toe gets swollen. It is often gout, but it can be another diagnosis like psoriatic arthritis. In this case, the toe that you can see here shows the tophus of gout, so it's fairly easy to say, okay, this looks like gout. In this picture here where you see a swollen wrist compared to the other side though, it could be gout or pseudo-gout, which is another type of crystal arthritis. So it's a different crystal altogether and treatment is different. In this picture here, you can see these lumps around the fingers. Now this can be osteoarthritis or it can be gout. And in this picture here, it looks a little bit like rheumatoid and it could be gout or rheumatoid. These are pictures of tophi. They most frequently appear on the ears, toes, fingers and elbows. And you can see here around the ear, there's little white dots. They're tophus. We've seen this picture before, and this is a picture of a joint of a finger that looks like it's got osteoarthritis, but there's tophi there as well. You can see the little white dot. And at the elbow, it's usually at the back of the elbow, what we call the olecranon bursa. There's a little cushion of fluid there that often gets gout crystals in it, and that can get swollen and inflamed as well. Now, 30% of people who don't have treatment will develop tophi within 5 years of their first attack. And most commonly, the attack is in the big toe. It can spread then to the ankle, to the knees, to the hands and elbows. And that's often the pattern of the way it goes. Now, these are the x-rays I mentioned where you get bite-size, like bites taken out of the bone. And so this is a finger joint, and you can see this big bite taken out. What you can also see is a little bit of soft haziness around it. That's actually a tophus, and it's eaten into the bone there. You can see a similar thing here. There's this big sort of haziness around the tip of the finger, and the bone is sort of eaten away here. You can see a similar thing here on this finger with a big tophus there and the bone eaten away. And this is a picture of the big toes, or the part of the foot. And you can see a big lump of tophus there. And then the bone is looking very mottled because the tophus has eaten that joint away. So it can be quite destructive. But sometimes we can't get fluid out of a joint. Either the joint is too small to be able to get the fluid out, or for technical reasons it's difficult. And so we need to use other ways of being able to diagnose gout sometimes. A blood test alone that shows a high urate level is usually not enough. It is supported by the typical presentation of someone having a very hot, swollen joint. It typically will come on, last for maybe a week and go away, and then there'll be a period where there's nothing, and then they might get another episode. It might be in a different joint. But episodes like that are very typical of gout. It often will respond to colchicine. Not always, but if it does, then that's more indicative of gout than another diagnosis. And when the attack settles, if the urate level is very high, although it can be normal, but if it is very high, then that's more indicative of gout, but is not a diagnosis on its own just by having a high urate level. We can also do a dual energy CT scan. Now this is a very specialised CT scan that only certain places will have available. There's several scattered around Australia that do these types of scans. And what you see, for instance, this is of the feet, there is loads of uric acid crystals in the green. So it's represented by these green blobs, tophus, essentially all through the feet. You can see here's a picture of a foot, but there's only a little bit there on the toe and just some tiny amounts here. And then if you look at the hand, you can see this is in the wrist, and then a big blob there on the index finger, and then a few other scattered around. So that's what we may have to do if we can't prove gout and we're not sure if it's a different type of arthritis, for instance. So how do we treat? Well, we have two principles in treatment. One is to settle the acute inflammation. The reason why they've come to you is often that as a doctor, They've come because they've got a lot of pain in one particular joint usually, and of course they want that treated. So we want to treat that first. And then we want to look at long-term, how do we stop this from happening? And that is by reducing the body load of urate crystals. So we're getting back to our case, Mr. AB, and he has this swollen red ankle, which we want to try and treat. The first thing is to educate him about the nature of gout, what the risk factors are, and look at diet. And that's a complicated thing, diet, so I'm going to talk about that a little bit later. I also always give patients a attack management plan. So that is whenever they get an attack where a joint becomes very inflamed and sore, what do they do? I give them a plan, and which I'll come to a little bit later as well. And then the goal of treatment is that eventually we stop these attacks from happening by getting the serum urate level down. I may give him a joint injection, particularly if I'm taking fluid out of a joint. I might as well give a cortisone injection at the same time, and that can be helpful to quickly settle things down. Sometimes just taking the fluid out of the joint relieves the pain straight away. We use NSAIDs, non-steroidal anti-inflammatory drugs, or anti-inflammatories, you may know them as, and there's about 20 different ones. Nurofen is one of them, Voltaren is another, for instance. Now, they're what we say contraindicated, so they're medicines that we can't give to everyone. So if someone's had kidney disease, for instance, or if they've had a stomach ulcer or got a stomach ulcer, or on blood thinners, then we wouldn't want to be giving anti-inflammatories. So we use them in some people, but not in everyone. So that's what I mean by if not contraindicated. Colchicine is a medicine that we frequently use in gout. It can be used by taking 2 tablets straight away and then 1 tablet an hour later. And sometimes you can use up to 4 tablets a day after that. But usually 4 tablets a day is not very well tolerated because it can cause diarrhea. So you hope that people can get by with just taking those 3 tablets at the beginning and stop the attack. Now, if they don't work or people can't use those medicines, then we use prednisolone. Prednisolone's a corticosteroid, Solone, panacordolone, prednisolone, they're the different brands that you may have heard of. The problem with steroids like this is that they have a lot of long-term problems. So we'd use it in the short term if we have to, and as low a dose as possible because of the long-term side effects. In the short term, it's not so bad, but it can increase blood sugars, can affect blood pressure, it can increase the risk of infection. So there's a lot of problems with prednisolone. They definitely need something else if needing a lot of prednisolone and having a lot of acute attacks, so that in the end you're having a lot of prednisolone. So I would definitely be trying to use other treatments in that situation. So let's just look at the risk factors for gout. As I mentioned earlier, kidney impairment, because the kidneys wee out the urate, and if we're blocking that, then the urate builds up in the blood. Some medications can also increase the risk of gout and increase the urate in the blood. Diuretics, for instance, you might have heard of these. These are medicines that make you wee out more, which sounds paradoxical, but for some reason they give you more water out, but the urate gets retained. And they're what we call thiazide diuretics, or there's others like the frusemide, which is a loop diuretic. Other medicines are like aspirin, alcohol, if you call that a medicine, and then there's some rarer ones that are used as well that can also increase the risk of gout. So other risk factors, as I mentioned before, was metabolic syndrome as well. So we do try to manage that if we can. We might try to minimise medications to reduce the risk of gout. And I mentioned already that some cancers and high turnover of cells, like in psoriasis, can be a risk factor. There is genetics that have a play in the risk of gout. Usually this is in people who are getting gout at a much younger age. alcohol does increase the risk of gout, and diet, and I'm going to go through that in a little bit more depth later. So I'm sorry about this slide. It is quite, I think, small and difficult to read, so I'll just take you through it. So this was a study that was done and published in the British Medical Journal in 2018, and they took over 16,000 people from about 5 different studies where they looked at diet and looked at their serum levels of urate. And these were all European-born Americans. And what you can see, the purple lines past that red dotted area represent where the urate really increased. The yellow lines are the ones where there was a protective effect, where it had a negative effect on the urate levels, so that's good. And where the purple lines were increased is when we're seeing it was 7 major food groups. So it was mainly meat, like red meat, lamb, beef, offal, are commonly associated with gout. What we see is protective, though, is dairy, for instance, like cheese and like skim milk. These were more protective. Peanuts were protective. Cereals were somewhat protective. A lot of people talk about tomatoes. Now I'm just trying to find where that's down here. So a lot of people say, oh, tomatoes give me gout. And it may be that individually they do, but as a whole, when we look at the big studies, we're not seeing that bear out really. Certainly beer. Let me find beer for you. Here we go. This one here is beer. This one's liquor, and this one's wine. So beer is, by the nature of the way it's made, it's high in purines and is associated quite heavily with increasing the urate levels in the blood. I'll go to the next slide actually. This is a list of the foods that are high in purines. So red meat, offal, seafood, for instance, yeast-based food, so beer and Vegemite, would you believe, because it's a breakdown product from beer. Certain vegetables as well, which you might find interesting, but I don't tell people to limit their vegetables. Now, the reason why purines lead to gout, this is not meant to be complex, but it gets broken down to these chemicals and then to uric acid or urate, for instance. This is where some medicines act on to stop the urate from developing in your body in the first place. Now, animals don't tend to get gout because they have this extra enzyme that breaks it down further to allantoin, which is easily just weed out in the kidneys. But in us, we stop at the uric acid, and that builds up into hyperuricemia. So that's how food is broken down and leads to the urate in the blood. So from a diet perspective, I generally recommend to people to have a healthy diet that is filled with vegetables. You do not need to cut out purines, foods high in purines, or fruit at all. But I do recommend limiting alcohol, though, particularly beer, to healthier levels, or abstain if you're getting recurrent gout attacks because of beer. We have changed our recommendations in the last decade really because what we've seen with the studies is that diet does play a small part. In some people it's more important than others, but if we treat adequately with the medications, then the diet really takes a secondary role. So I'm now going to talk about the acute attack plan. What would I do and this is an example of an acute attack plan for someone, but it does need to be individualized. So I would give colchicine, 2 tablets straight away, and then 1 tablet an hour later, and you start colchicine as soon as you feel those symptoms of a gout attack, because the sooner you get it, the better it is and that you'd respond to it. Now, if that hasn't worked, then the next day you'd have 1 or 2 or 3 tablets a day, depending on how sensitive you are to it, because some people can get diarrhea even from 1 tablet, you see. But you would take that up to a week until the attack resolves. If colchicine doesn't work for you, or you have problems with colchicine and you can take anti-inflammatory medications, I would often use naproxen or naproxen 1 gram a day. And if that doesn't work or you can't take it, then I would use prednisolone. And I'd often use a dose of about 37.5 milligrams, which is about 1.5 of the 25 milligram tablets. Some people need even higher doses, and some can get away with 25 milligrams. And really that's just something that you work out over time with the history. And then I reduce that dose every couple of days by about 12.5 milligrams to cease. So usually it's over about 4 to 6 days that someone would be on the prednisolone, and then hopefully off it completely. So back to our case and management. So the acute attack, the swollen ankle, is treated with an anti-inflammatory called diclofenac, or Voltaren, you might know it as. He had 50 milligrams 3 times a day, plus he had a cortisone injection at the time that fluid was taken out of his ankle. Education I mentioned. And then once it was stable, the ankle was no longer inflamed, I repeated his urate level and I considered commencing allopurinol. Now, some of you may have heard of allopurinol. It's also known as Xyloprim or Pro-Gout, for instance. This is a urate lowering therapy, and it's been around in Australia for years. It's a very common medication that we use. But the urate lowering therapy rules have changed a little bit. So these are recommendations for the management of gout that were all aligned across America, Europe and Australia. That we give urate lowering therapy, and I'm talking about allopurinol here, but another one called febuxostat, which I'll talk a little bit later about. We give that to people if they've had more than one attack of gout. So if they're having recurrent attacks of gout, then we would give urate lowering therapy. When we give therapy, then we want to treat it so that the serum urate level is less than 0.36. If they've got TOPHI, even lower at 0.3. And this is because what we want to do is bring the crystals out of the joints into the bloodstream and broken down and then out of the body. So by doing that, we're ridding the body of gout crystals. Now, if someone's had gout for a long time, that could take years. If it's fairly new sort of gout, then it doesn't take as long to do that. When we start urate lowering therapy, the changes in the urate that occur can bring on a gout attack. So we have to give what we call is prophylaxis. That's where we're giving something to prevent a gout attack at the same time as using the urate lowering therapy of allopurinol. So we either use colchicine or an anti-inflammatory. Sometimes we have to use prednisolone, and we give that on a daily basis for 3 to 6 months after we've stopped changing the urate lowering therapy. I know that's a little bit confusing, but I'll go over that again soon. Depending, of course, other medical problems will be the decider as to whether we use colchicine or anti-inflammatories or prednisolone as the prophylaxis treatment. We should never really start the urate lowering therapy, such as allopurinol, when someone has a gout attack at the time, because it actually can make it worse and make it more prolonged. So we wait until it's subsided, usually about 3 to 4 weeks, and then start it. We always start at a low dose and build up, because if we give a very high dose straight up, or not a very high dose, even a usual treatment dose straight up, then that can bring on quite a bad gout attack. So we start low and build up, and in particular if there's kidney problems, we start a little bit lower. So these are the urate lowering agents that we have in Australia. So there's allopurinol, as I said, has been around for many years. It's sort of the main medicine that we all would use as rheumatologists. We use it in doses of 100 to 900 milligrams. And it only needs a dose reduction at the beginning if someone has kidney problems. Other than that, we can use the same dose that we would use for everyone. Febuxostat is sort of newer. It's probably been around about 5 years. It seems to be a bit more potent than allopurinol. We're only allowed to use it in Australia if you've failed allopurinol or had a bad reaction to allopurinol, and then we can use the febuxostat. And they come in 80 milligram tablets, so you start off with a half a tablet. You might take that for 3 or 4 weeks and then go up to the full tablet of 80 milligrams. Probenecid has been around for a very long time too, I think since the 1940s. It is not used very much. We can't use it in people who are not weeing enough, and it's got a few limitations, so we only tend to use that one if we've got no other option. So as I mentioned, if we were to start urate lowering therapy, we have to start at a low dose and build up slowly because it can bring on a gout attack. So we have the prophylactic treatment as well initially. But if someone does get a gout attack, then we treat the gout attack in its own right using the attack plan. Because if we were to stop the urate lowering therapy, which is what was frequently occurring even now, I see that people stop their urate lowering therapy when they get a gout attack, and they shouldn't. They need to keep staying on it, because when you stop and start it, the urate levels are going up, down, and of course that just makes everything worse. So you're best to stay on the urate lowering therapy, treat the acute attack in its own right, it will resolve, and you stay on the urate lowering therapy. So yes, so we tell people that this can occur. The prophylaxis I mentioned to prevent the flare while we're stabilising the dose is the low-dose colchicine, which is, some of you may know this as Len-Gout, for instance, or Gout. They're the brand names. So that's 1 tablet twice a day, or 1 tablet daily might be enough. In some people super sensitive, I might even use it 1 tablet every 2nd day. This is the anti-inflammatories or coxibs, so for instance naproxen, Voltaren. A coxib might be Celebrex, for instance. But depending on other medical problems, as I mentioned, we may not use those medications. And then we slowly titrate up the urate lowering therapy, meaning that we might start at 100 milligrams of allopurinol, build up to 200, build up to 300 milligrams until the urate levels are at the level we want them to be. So let's get back to our case. He didn't turn up for 18 months and then comes back, and he's had several episodes then of painful swollen joints in his knees and ankles. His urate level was 0.56. He'd just been started on allopurinol 300 milligrams 2 weeks ago. So he wasn't built up slowly, he just went on that by his GP. He now has a very swollen, painful right knee. The rule here is do not stop the urate lowering therapy. He's been started, he's got a gout attack, we treat the gout attack in its own right, but continue on the allopurinol 300 milligrams daily. So then he comes back after 2 months. His acute attack had been treated. I'd given him a cortisone injection. He stayed on the allopurinol 300 milligrams a day. I'd also started him on colchicine 1 tablet a day, and he had the diclofenac or Voltaren if he needed it. He hadn't had any further attacks. His urate level at that point had dropped, but it was still more than I would have wanted. It was 0.43, and in someone who doesn't have TOPHY, I want it below 0.36. He'd reduced his alcohol to 2 or 3 beers on weekends, and he was watching his diet. So what's the next thing? What I would do then is increase his allopurinol because I want his urate level below 0.36. So he was on 300 milligrams a day. I increased it further to 400 milligrams a day. He stayed on background colchicine because we want levels below 0.36, sustained at that level for quite a while to stop the gout attacks. Now there's a few problems with allopurinol and febuxostat or any urate lowering therapy. As I've already alluded to, starting and stopping can bring on an attack. So we need the background preventers until stable dosing occurs for 3 to 6 months. A lot of people stop their medications. It can even happen inadvertently when you're in hospital and not even aware of it, and that destabilizes the whole thing and can bring on an attack. And some of you may have experienced a gout attack while in hospital. That can be for several reasons. It can be because the urate lowering therapy was stopped. It could be because you've given diuretics. It could be because you've had fevers or unwell or dehydrated. Many of those are risk factors to bring on an attack while in hospital. We build up the dose of allopurinol slowly, so it does take quite a bit of time to get the urate level to the right level. Unfortunately, that is the downside of allopurinol. It's a little bit quicker with febuxostat. Also, as I mentioned earlier, if we're treating gout quite late, it can take years to stop the attacks. Now, 2% of people can get a bad rash with allopurinol, and it's 0.5% with febuxostat. And people can also get kidney or liver problems from either of them, so that does need to be looked at. We would not be using febuxostat in someone who has heart disease because there are some problems with febuxostat, particularly if someone's got heart failure or even had heart attacks. And there's some medications that will interact with these, azathioprine and mercaptopurine, for instance, but they're not commonly used. So what happens if someone does develop a rash with allopurinol? Well, it can be a very nasty rash, so I need to stop the allopurinol straight away. And then I would change the allopurinol to febuxostat and start at the half a tablet, 40 milligrams, for 2 to 4 weeks, and then go up to the full tablet again. But they would need the background prophylaxis that I mentioned before as well. I also mentioned probenecid before, but that's not used. It would be a third-line treatment. So these are the 5 rules for gout. First of all, as a doctor, I want to prove the diagnosis, and I want to do that by aspirating a joint, or taking fluid out of the joint and seeing those crystals under the microscope if possible. I want to consider and treat risk factors so it's easier to treat the gout as well. I then educate the patient about what gout is, how it's likely to go with treatment because of the pitfalls that I've already talked to you about. I write an acute attack plan and manage the acute attack if they've got one there when I'm seeing them. And then if they're having recurrent episodes or they've got TOPHI, I want to treat with urate lowering therapy. And these are the rules of that urate lowering therapy. So we do not stop the allopurinol or febuxostat unless there's side effects. We're best to wait until the acute flare settles before commencing it. And I usually would commence allopurinol about 50 milligrams to 100 milligrams daily, or febuxostat 50 milligrams daily. Sorry, 40 milligrams daily. I give background colchicine, anti-inflammatories or prednisolone as preventers until the dose of the urate lowering therapy stabilizes. And even if a patient has a flare, they need to continue their urate lowering therapy and use their attack plan to treat the acute attack. And I treat to target. I titrate the dose of the urate lowering therapy to the serum urate. That's what that SEUA means, serum urate. And I do that slowly by increasing the urate lowering dose. So for allopurinol, that's what I might do. I might, if they've got kidney problems, I might start at even 25 milligrams or 50. And in someone with normal kidney function, I might start at 100, and then I build up every few weeks. I might stop here at 300 if that is enough for the serum urate. And in people who are resistant, I might use a higher dose. Or for febuxostat, 40 milligrams, and a few weeks later up to 80 milligrams if needed. So this is further reading. If you want to read more about gout, then I would recommend these websites. So thank you, everyone. Free for questions now.
Thanks very much, Tina. That was a very comprehensive presentation and such a, a critically important condition, because I know at Musculoskeletal Australia we certainly get many queries, and a lot of the information on our website is regularly downloaded by people. So that's one thing that I just had in mind. The incidence of gout within Australia currently, what is that at present?
To be honest, I don't know, Jen. I haven't looked what the latest is. It is increasing though. It's something to do with our diet and I guess increasing obesity. So I'd have to tell you I don't know what the exact figure is. It's actually worse with our New Zealand colleagues because the Pacific Islanders are much higher risk as well. So they have a much higher rate in New Zealand than in Australia.
And of course I should be encouraging people to type in questions. If you have any questions about the presentation, don't hesitate at this time to actually type in your questions now into that question box. So Tina, you mentioned the case you were presenting throughout the presentation, Mr. AB. I think you said he was about 49. Is there a fairly typical age group, or males versus females? What's sort of the demographic profile of many people who may be suffering from gout?
Sure, it is more prevalent in males than females. If a young female came to me with gout, I'd be thinking there's a genetic risk. So for whatever reason, females, it tends to occur later in life if they get it. And males, yeah, 49's a fairly, or 40 to onwards is a fairly common age to see it. Some will even say, oh yeah, I had a big toe swollen when I was 30. I didn't know what it was, it went away.
Right.
So yeah.
And one of the questions that has come through, there's someone has asked about the fact that is there any role for physiotherapy in treating gout? Because from your presentation, it certainly looks like it's presented far more medically.
Yes, so what I've presented really is treating the gout to prevent the urate crystals. But of course, where a joint is affected, then there's a role for physiotherapy to help someone gain range of movement back and to strengthen up around the joint, because often there's associated osteoarthritis. So osteoarthritis means damage to a joint, essentially. And when there's associated osteoarthritis to a joint, there's going to be muscle weakness around it, and certainly physiotherapy can help guide patients in terms of strengthening up around the joint and getting joint movement back.
Okay, and so there's another question obviously around physiotherapy, and actually it did come to mind because obviously people would present to their GPs probably initially. So, you know, what sort of at what point, or what are the indicators that a GP needs to refer a patient onto a rheumatologist? Like, is it commonly treated for a while by a GP, or should they be a patient be referred to a rheumatologist fairly early on in the piece?
No, not necessarily. I think it depends on the comfort of the GP. If the GP is quite comfortable with managing gout and is doing that effectively and successfully, there are a lot of patients who are treated by their GPs, and I never, you know, us rheumatologists never see them, and that's good. I do tend to see the more complicated cases. So it's often when a GP has had trouble with it, not quite sure if it is gout, because as I said, it can be a different type of arthritis as well. So that's the ones I commonly see, but sometimes I'll get a simple gout case.
Mm-hmm. Okay, and is there a role at all, Tina, in relation to massage therapy, particularly in sort of increasing circulation to affected areas?
Not as far as I'm aware. I wouldn't be aware of any studies that have been done for that. I'd be a little, like if there was tophus present, I'd be a bit worried about massaging that area and inflaming it more. So I'd be a bit hesitant about massaging a particular area where it's a gout attack is happening.
Okay.
Yeah.
Okay, thanks. If a person has osteoarthritis, is it likely to, is there greater potential for it to develop into gout, or really are the two quite separate in relation to the conditions?
So they are separate in that just because you have osteoarthritis, which is really, really common, I mean, most people would get osteoarthritis in a joint at some point in their life, but not everyone gets gout. So osteoarthritis is really common and it is separate to gout. But if you have osteoarthritis in a joint, that is probably going to be a joint that does get gout in it if you develop gout. If that, hopefully that makes sense. So yes, we do see gout more commonly in osteoarthritis joints. The other side to that is, as I pointed out with the x-rays, is that gout can cause osteoarthritis just by simply destroying a joint.
Mm.
So it can
Yes.
go different ways.
Okay. And again, just a question around, are there any other non-medication options to help with symptom management? For example, does ice help to reduce swelling or pain?
Absolutely. So yes, you can do whatever makes it feel more comfortable. So that's because it's red and hot and inflamed, often the opposite. So icing is probably going to help. Now, of course, that's going to reduce blood flow, but that's what you're trying to do by icing it, is getting rid of the blood flow that's causing the redness. So it's really comfort measures that are likely to help. Not being dehydrated, drinking plenty of water, that will generally help as well. Sometimes people can rub on Voltaren gel instead of Voltaren tablets, for instance, if they can't take the tablets. There's foods, as I mentioned, that are more protective of gout, but if you've got a acute attack, taking those foods is not necessarily going to help. It's sort of, that's a more of a long-term in your diet sort of thing. In terms of natural medicines, there's none that I'm aware of that are going to be have been proven to be preventative, for instance.
Yep, thanks, Tina. So, and how do you treat the gouty tophi when they're breaking through the skin?
Yeah, that can be very nasty. I'm not an advocate for getting surgery on them. Sometimes people do. The problem is it's treated by the body as a foreign object, and that's why there's the inflammation around it. So it doesn't heal well. So when there's urate crystals there, and even if you get it surgically removed, you can't get rid of all the urate crystals, and so the healing is usually pretty bad. So I don't in fact, I don't think I've had, or maybe I've had one patient in the last 10 years who's had surgery on his toe to remove a tophus. So it's sort of not commonly done.
Mm-hmm.
Otherwise, you try to dress it so it doesn't get infected, because you can get secondary infection into the tophus, which can be a bit of a nightmare as well and may require surgery if that's the case. But otherwise, then we rely on the body getting rid of it very slowly, which can take years if they've got lots of urate in the urate load in tophus.
And Tina, in the acute swollen phase of gout, should you apply bandages?
No, that's probably just going to warm it up. So I would only do something that makes you feel comfortable, really. Then it's not going to change the it's not going to change how quickly it resolves or anything like that. So we talked about icing before. That will make things more comfortable, and you can have pain relievers, of course, to as well, but that's just more about comfort measures.
And is physiotherapy best started after an acute attack?
Yeah. Yes, exactly. You don't want to be having treatment on a joint that's acutely inflamed. That's really not going to be helpful or comfortable.
And again, getting back to the ice, is ice therapy helpful in the acute phase?
Yes, so that's what I'm talking about. Ice therapy at other times is not going to be particularly helpful. So it's only when it's hot and inflamed that it's likely to give comfort.
Mm-hmm. And how do you treat high urate if there's no gout symptoms?
Yeah, so that's actually quite a controversial issue, and a lot of studies have looked into that because the theory, of course, is if you've got a high urate, then you're more prone to gout. Should we treat high urate then to prevent gout in people? And no, we'd be over-treating too many people if we were just to treat the blood test alone before people ever had any gout attacks. So it's not recommended that we do that.
Mm-hmm. A very specific question, can sour cherry juice help with gout?
Actually, yes. Sorry, I did not mention that in the diet, and yes, that has been shown to be helpful. Cherries can be good for an acute attack too.
Mm.
Thank you for reminding me on that.
Okay, that was an interesting one. And what's the difference between gout versus pseudo-gout?
Okay, so they're different. They're both crystal arthritises. As I've gone on tonight, gout is due to urate crystals or uric acid crystals. Pseudo-gout is due to a different crystal altogether called calcium pyrophosphate or CPPD. And it looks very different under the microscope. They're blobs of crystals. They don't look needle-like at all. They look a little bit like pink. They're very hard to pick. You saw lots of urate crystals, needle-like crystals under the microscope when I showed you those pictures. You might see one or two little blobs under the microscope. So it's often missed actually when we take fluid from the joint, and that always makes me wonder, is it CPPD? But it looks and smells otherwise just like gout. So it is an acutely inflamed joint. Often it's the knee or the wrist, so that will get inflamed with CPPD. So yeah, it's a different type of crystal arthritis. Sometimes we use colchicine. I often find it's not all that helpful. Often we have to use prednisolone to treat it.
Is there any evidence, Tina, for exercise as a preventive factor to reduce the recurrence of gout?
No. So I'm a big advocate for exercise, and where exercise might help is in the risk factor of metabolic syndrome. That's a risk factor for gout. But no, exercise as a gout treatment, there is no evidence that that's helpful.
Mm-hmm. Do you believe, Tina, that gout can be expressed or developed from stress and then transferred on genetically to the next generation, also sort of in conjunction with bad diet?
Let me tease that out a little bit. So I think stress can bring on a lot of problems, and you know, but you've already got to have the gout in the first place and the potential for gout to for that to flare up. So stress on its own, I don't think causes gout. In terms of it altering genes, I don't think so. I don't think that would be then a cause for you to be passing gout on to the generation. I think you've got that genetic profile, and then that profile is passed on to the next generation.
Mm. And someone sort of mentioned, or I've just written a comment here, that they used to get gout very badly in their ankle, but they now seem to be getting it in their elbow joint. At least the person thinks that it is gout. And you sort of covered that before about the fellow who came back after 18 months, didn't you? That it was then, I think, in another joint.
Yeah, so it does commonly start in the big toe. We call that podagra. And then it can go to the other joints like the ankle, the knees, the hands, the elbows, and so yes, we often see that sort of starts in the toe and then goes up to the arms, and so it's often in the back of the elbow that people get it in the, not the elbow joint itself, but it's a bursa at the back of the elbow.
Mm-hmm. If gout's present in a lower extremity like a foot or an ankle, is it better to offload the joint for reducing the inflammation with regards to, are there any particular weight-bearing restrictions in relation to the management of gout?
I think people will do that anyway because gout is often exquisitely painful. So even sometimes people describe just putting a sheet on it is very painful. So often people don't want to walk on that foot anyway. So I think it really comes down to the person and how debilitated they are by the pain as to whether they want to use a crutch, for instance, to offload the joint in the foot. That's reasonable if it's feasible for them. But will it actually make a huge difference to the recovery? It may do a little, but I don't think dramatically so.
Mm. And how quickly do foods cause gout? Like, for example, someone's asking if they ate a high purine food or diet, sort of at this time, how quickly might gout flare up if it's sort of linked to that food?
Well, that's quite an interesting question, because often you'll hear from your patients that they'll say, oh, I had lobster last night and now my toe's all inflamed. And that is not uncommon. Or I had a big weekend and it's Monday, and so it can be within hours or days of eating something that triggers their gout.
Another question, would dry needling help?
No, I don't think so. In fact, I wouldn't be sticking needles into a tophus either, again, because of healing issues. I'd be worried about that. You'd want to be cautious about doing that to sort of, diagnosis reasons, for instance, and then avoiding it if possible.
A question, GPs prompted referring, or do you think they sort of, that you tend to see patients that have been referred to you a little bit too late, so that things have progressed and worsened?
Oh, look, I get a mix of both. As I say, it depends on how comfortable the GP is in managing it. It also depends on the patient. So as you saw with the patient that I presented, some people are not ready. They're not ready to accept that this is what it is and undergo the treatment, because it takes a commitment. As I said, you can't stop and start. You need to stay on it, and so sometimes people are presenting late because they're not ready to accept that they actually need to have the treatment, and change their diet, for instance, or change their how much alcohol they're drinking, and so they're avoiding it. So people can present quite late, and I see some that are early as well.
Just following on from an early question, just asking for clarification, you mentioned that gout can potentially cause osteoarthritis, but can osteoarthritis cause gout?
No, osteoarthritis doesn't tend to cause gout. You have to have that propensity there to deposit the urate crystals into the joint. So just because you have osteoarthritis doesn't mean you're going to get gout.
Okay. All right, and listen, look, there's a couple of other questions. I can check with you, Tina, whether you might be happy to answer those offline. We can provide those to people later. However, we are right on 8 p.m. Australian Eastern Summer Time, and in fairness to Tina and everyone who's tuned in, we might finish there. I would like to once again thank you, Tina, even from the questions that have come through. You really generated a lot of interest, and that was a fabulous presentation on a very important topic. So thanks again, Tina. I'd like to thank everyone for joining the webinar this evening, and ask that if you take a few moments, just or probably even less than a minute after we close the presentation, to answer our feedback survey. And I also urge you to look at our other webinars and hopefully register for those as well, because they certainly cover a range of interesting topics. So on that note, I'll bid everyone a good evening, and hopefully we'll tune in with you in April at the time of our next webinar. Good night.
Good night.